The study that I'm presenting today deals with postoperative mechanical ventilation in patients undergoing major oncosurgery and was carried out at the Tata Memorial Center in Mumbai, India. So we know that anesthesia for oncosurgery is complex and associated with critical perioperative events. We wanted to prospectively examine the reasons associated with postoperative mechanical ventilation and look at the association between ventilation and patient and surgical factors. This was a prospective single-center observational study carried out after approval from the Institutional Review Board. We included all major elective and emergency cases over a 3-month period with data extracted from operating room records, anesthesia charts, and electronic medical records. We found that the incidence of postoperative ventilation was 112 out of 1887 cases, which is 6%. The most common reasons, as described by the anesthetist, were hemodynamic instability and respiratory insufficiency. Out of these 112 patients, 83 patients were not given a trial of reversal, whereas 29 patients failed a trial of reversal and hence were shifted on ventilator. When we looked at the relationship between age and mechanical ventilation, increasing age was associated with an increased risk, with patients in the age group of more than 80 having almost 10% risk of getting ventilated. Among surgeries, colorectal and neurosurgeries were associated with the highest risk of postoperative ventilation. Complexity of surgery was also associated with a risk of ventilation. So supramajor surgeries had almost 8% risk of ventilation as compared to 1.6% in major surgeries. And increasing ASA grade was also a risk factor. So ASA 2 patients had a 4% risk, whereas ASA 3E and 4E patients had a 25% and a 43% risk of getting ventilated. So the risk factors that we identified were older age, complex surgery, gastrointestinal and neurosurgery, and higher ASA grades. So the rate that we found in our study was higher than in the general surgical population, possibly because these are complex cancer surgeries. Most of these were planned elective ventilation. We identified certain groups at higher risk, and this data may be useful for counseling and resource allocation. The strengths of this study are that it was a large sample size with a high event rate, and we combined self-reporting with record review to reduce underreporting. But the limitations are there was no long-term follow-up, we did not do a root cause analysis, and the results may not be generalizable beyond cancer surgeries. Thank you.